Bismillahirrahmanirrahim. Dear students, viewers, and learners, uh, from core of my heart, thanks everybody to join me. So we are going to define a pulmonary mass. This is really not asking you to go through a text. I just want to make you decide about the pulmonary mass. You have got a chest X-ray all the time you were in practice or in class or in work, you have a black paper of X-ray, and you should not miss a pulmonary mass wherever you are. So I am trying to make you educate whether this is a pulmonary mass or not. Because when I was a beginner, I was shaky to decide whether this is a mass, whether this is a consolidation or a collapse, or this is extrapulmonary or intrapulmonary. So, from my point of disability, I like to make you to understand the ABC of chest X-ray so that you are not going to miss any pulmonary mass, right? And again, how to decide a mass? Whenever you get a shadow in the X-ray, you have to decide that this is a mass or not. Mass means this is not a simple infection, this is not a simple collapse, and you are not going to miss any lesion. Might be mitotic. That is what your eye need to be expert. Your mind need to be oriented very nicely, because you know the incidence of the malignant lesion in the lungs contributes the highest death rate among all cancers in the body. And this is very much next to the cardiac death. This is bronchogenic carcinoma. And what is your job? The patients roaming around, either ill or not, either not seriously ill, but you need to declare that you don't have any problem, you are not having any mass. Then what is that you need to go through? This is any obvious mass lesion you can get. Whenever you are going to get a lesion, obvious mass lesion that is seen as an isolated lesion in the lung, you had decided that yes, this mass is present in the lung and it has got a regular or irregular, smooth or spiky outlines. That is something you need to declare, that yes, the isolated mass would have a chance to be malignant or a chance to be benign, that it is an isolated mass with margins to be considered. Not always that you are going to have an irregular spiculated outlines of a malignant mass. Sometimes, or in a significant number, you will have a smooth outlines. So the job is, you have got an obvious isolated mass in the lung, and the outlines are also to be decided, because yes, the smooth outlines does not rule out the presence of mitotic lesion. As well, there is irregular outline justifies the obvious presence of a mitotic lesion underlying. So this is a simple thing you will come to be decided, that yes, there is a mass lesion and the possibility of the malignancy, how much. The most of the thing in this case, isolated mass, can be gone through by you at student life and also in the wards. So this is a type of presentation of isolated mass with irregular outline, or maybe there is smooth outlines. And the second type, there is local anatomical distortion. It means the bronchovascular markings are following a definite distribution, shape, and position of the vessels and bronchi. Whenever you have got any atelectasis in relation with a mass, uh, uh, different differential density in a lesion produced by the mass and also consolidation. So there is anatomical distortion. We have to understand that. Yes, there is a lesion seen here with local anatomical distortion, whether there is cut-off of the bronchus or cut-off of the segmental bronchus, local atelectasis or consolidation. And this is anatomical distortion will make you an alarm of presence of mitotic lesion. And finally, the mediastinal shift due to bronchial or mediastinal invasion. Whatever the cause, what we need to help the patient around is early detection. Even with all the situations, all the bargainings, what can help a patient really is early detection of a disease. That's why whenever you get a total lung collapse or a large mitotic lesion in a lung field, this really goes nothing in favor of a patient. What you really need to help a patient, a family, a society, a state is early declaration of a devastating outcome that you have got a lesion here and you need to have a very good follow-up, need to have a very precious measurement so that uh, the family, the society, the national burden gets reduced. Let's go through slowly so that end of the day we can have an assessment of the presence of any mitotic may be possible. Here is the thing I have discussed that there is an obvious lesion. This lesion is a perihilar lesion with hilar involvement, partially at least. And you see, this lesion has got a definite margin. This definite margin implies the presence of a mass. And you see the left hilum is seen through this lesion. And there is the left principal bronchus is leaving uncompressible. So this is a mass lesion seen here. This hilum, as it is seen through the lesion, I maybe just forgotten. I should mention that this is called hilum overlay sign. That is the normal hilar structure is seen through the lesion present in the lung. This is called hilum overlay sign. This means this lesion is not invading the hilum, means not from the hilum. It is either in front or behind the hilum. So what is the distinction here is a mass lesion present in the parahilar region of the left lung, and there is partial invasion at least of the hilum at suprahilar location. So this is a simple presentation and the very known presentation of the mitotic lesion. As undergraduate students, they will be able to read such a large lesion. Not there is no possibility to miss such big lesion to be mitotic. A very simple thing for you, everybody, I think. And the mass, yes, will give you a fair judgment of mitotic lesion, but what about a consolidation that is having slow resolution? Whenever there is a whitish shadow in the lab, we usually think of, oh, this is a consolidation. Yes, this may be a consolidation, but sometimes it is not a simple consolidation as we are thinking. Some things we have to go through, that whether this slowly resolution state of lung consolidation, some important parameters, some important clues we have to find out, that whether this is a mass or a possibility of tuberculosis, and the other thing is the possibility of immunosuppression. These three things you have to rule out. What is a slow resolution means the therapeutic response is reduced in a consolidation. Usually you used to have, so whenever you need to declare a simple consolidation or a possibility of a mass or tuberculosis or immunosuppression, we need to have a very good follow-up in a patient with a suspected consolidation. We need to have a second X-ray on uh, 2 weeks later, and we have to compare the next X-ray with the previous one. Whether it is a mass, a tuberculosis, or in a state of immunosuppression is running with the slow resolution of consolidation is very important part of study of a pulmonary mass to be declared. And we are now at the features of collapse consolidation as a result of mitotic lesion causing bronchial obstruction. You know, and this is a white right lung. Whenever there is almost the mediastinum is shifted to the right, the trachea is shifted to the right, and the whole of the right lung is dense and almost homogeneously dense it is, and obscuring the silhouette of the right pericardiac, right cardiac border and the right hemidiaphragm. So something else is here producing this collapse and associated consolidation and effusion. This is one of the important presentation pattern of the mitotic lesion involved in the hilum. And we know the most of the bronchogenic carcinoma are central or paracentral. So they are producing such sort of presentation uh, that there is a total pulmonary collapse and these mediastinal shifting. Also, there is collapse consolidation together and effusion. So this is another presentation pattern of the pulmonary mass. The hilar mass bronchogenic carcinoma is a dissection. And whatever you are saying about a mass, a clean-cut mass, what is seen in the lung is would be the context we need to study for the mass is the size is 3 centimeter above, and below 3 centimeter we are not really saying it as a mass, it is a nodule and the margins are spiculated, and the spiculation practically refers to a malignant lesion. There would be a cavitation, but again, I must make you to remind that the margins, whenever it is smooth, does not exclude the presence of any malignancy, hidden malignancy. The cavitation present in the mitotic lesion is thick-walled cavity, usually more than 5 millimeter thickness, and the inner margins are nodular. And whenever we have any suspicion of any mitotic lesion to be declared or to be suspected mitotic lesion, to go for a follow-up, we can follow a doubling time standard for the patient. Is usually the lesions, mitotic lesion in the lungs gets doubled by 1 to 18 months. So we can have a serial film by 6 months and 6 months and 6 months, that we may have changes in its size, and the doubling time can be assessed. Usually it is said that if there is no changes in size by 6 months, there may be no mitotic cells inside. The calcifications seen in the mitotic lesion maybe sometimes it is present, and the pores, benign calcifications and pores are and scattered. So this may make you to come to a conclusion that there would be a malignant or a benign lesion. And it is the hilar and mediastinal invasion. The hilar and mediastinal invasion, you can come to read from this X-ray that this X-ray is having a suprahilar mass marched with the mediastinum, and you see the left lung volume is reduced to the effusion small at the left CP angle, and a large right lung emphysematous changes, and this significant left hilar elevation present here, and this left hilar elevation and a left hilar mass implies to the phrenic nerve palsy in association, so that there is a hilar mass, mediastinal invasion producing the left hemidiaphragmatic elevation, and compensatory hyperinflation of the right lung. This is the pattern of mediastinal invasion, and that's how you can come to know that how stage it has got. Again, there is a mass seen in the left hilar. Again, there is left hemidiaphragmatic elevation, and the mediastinal shifting is seen to the left, and the right lung is hyperinflated. So this is another form of mediastinal invasion of a pulmonary left hilar lesion. And the mediastinal shifting, we have seen that there is mediastinum to be shifted to the involved side of the hilar mass, that is the widened mediastinum seen here, and there is mediastinal structures to be shifted to the left. This is all are the lymph nodes present, producing wider superior mediastinum and the cardiac dimension to be like this. And the most part of the heart is to be on the left side. So the mediastinum gets shifted as we have seen in the upper films here. This is a very typical picture of a mediastinal shifting uh, to be studied here. And this is really happens when there is collapse and mediastinal shifting is very obvious here. There is pleural invasion. We can go through that. This in this film we can see that there is a large mass and smaller masses are also seen in both the films. You see in this film there is a thickened strip of the soft tissue attached along the right lateral chest wall. But you see, there is no effusion to be present here. There is some effusion in the left lung field, and you see there is a mediastinal shifting present here because the right cardiac border is not at all seen. The multiple point shadows are noted in both the lung fields, and the largest one is here. So these thickened pleural strip is really not an effusion, because if it is effusion, it will be gravitated to the dependent part of the CP angle. So this is a pleural invasion present here. So whenever there is a pleural invasion that is outside the dependent part of the CP angle, or the whatever the patient's position, it is not residing in relation to the dependent part of the patient. This is practically a pleural thickening that is producing a soft tissue strip along the line of invasion of the mitotic lesion, not to be confused with pleural effusion. Here it is a pleural effusion present, and along the right lateral chest wall, this strip is really a pleural invasion. And finally, we are going to go through a skeletal metastasis. Whenever we are having a mass in the lung, we have to judge the another part of our total assessment as uh, the skeletal structures in the thorax and surroundings. You see that there is a blastic lesion seen in the rib near its angle. And you know, the angles of the ribs are the most common site to be implanted by the mitotic lesion. And you see that there is a lytic lesion in this humeral shaft at the near the periosteal, near the cortical margin, medial, and there is also some lytic lesion noted here and here. So, and this X-ray is really presenting a mass in the axilla. So the skeletal metastasis is to be gone through in a way that whether there is a hematogenous metastasis present along the thoracic case, or in the in the bones around the thoracic case, like the spine, the scapula, the humerus, the clavicle, or the neck and mandible. So this is the whole thing of a mass you need to study to declare that whether this is a mass and the mass to be a benign or a malignant issues, and whenever it is malignant, how desperate it is to be spread hematogenously. So this is all about our today's presentation. And if you have got any confusion, any question, you can go to ask me in the messenger. If you don't have any question, we are going to